have to even get academic development residents into the curriculum. So we're definitely still working on that, and at this point, because it's not required, we'll have to see how to maximally get people. People do like food though, so they said food and protected education time.
All right, next up, I'm sorry, we'll have to save questions for after.
Hi, good morning everyone. Thanks to the ASE committee for allowing me to present some of the data. Just to disclose, I'm a clinical excellence lead at Innovis Medical. We're actually exhibiting at the at ASE and APDS this week, but I'm a surgeon in the NHS, an orthopedic surgeon by background, and looking for the next button. Okay, fantastic. So, bit of an overview. I'm going to be talking to you about some of our pilot studies and how that came across, and how we essentially came to the conclusions that you'll see towards the end of the study, which is really about health economic study, measuring the financial impact of surgical training in an augmented reality approach. So if I show you some of these metrics that we received here, we essentially are using an augmented reality simulator, which you'll see out there, which is essentially measuring a number of metrics, as you'll see on the next page. Time to completion, distance traveled, so that's in meters, instrument acceleration, hand dominance, and time in view. But we focus specifically on two of the clinically relevant metrics, which are time in view, distance traveled and time to completion. And we were using LAPASS, which is the UK equivalent of FLS. So we were seeing with just 45 minutes to an hour on the simulator, depending on the task that was being benchmarked. So that was either the appendix for the earlier stats or for the vaginal vault closure for the gynae residents. We were seeing a completion time improvement in between 19 and 37%, and an improvement in distance traveled between 25 and almost 60%. And we were also measuring the self-confidence scoring at the same time, pre and post, and we were seeing an improvement, statistically significant improvement of up to 3.82 on the Likert scale. We also did the study for not just 45 minutes to an hour on the simulator, we did it for 2 weeks. We sent the residents home with a surgical box simulator to take home and practice. So the idea is to, obviously practice their depth perception and 2D to 3D to back to 2D to conversion, and understanding how to use the instruments as well. And we found that pretty much all the trainees, so this is N=4, just to be perfectly transparent, it's an ongoing study. We're at N=15 at the moment, and the aim is to get to N=20 by the end of this month. But in the preliminary results here, we can see that pretty much everyone improved. There was one anomaly in the distance traveled. One trainee had a bit of trouble with the box, but that happens, as we all know. But we were seeing up to improvement of 55% of distance traveled and up to 39% of completion time, which is fantastic. One of our highest scores was 66%. We then shifted gears slightly to a systematic review. We wanted to figure out exactly what were the benefits of augmented reality training. And just to be transparent, this was performed by Nottingham Trent University, one of our PhD candidates. It was not funded by us at all, so I'm just reporting Courtney's data on this. We found that augmented reality was a highly effective modality after looking at 26 papers through the exclusion criteria. Recommends multimodality training, however. So training centres that have AR, VR, traditional box trainer and cadaveric is probably the best combination of all. But AR was preferred because of the faster skills acquisition and improves procedural success. With regards to AR versus VR, it was preferred because it reflected the clinical scenarios a bit better, and the haptics were a bit more natural. They were using real instruments. And it was preferred to cadavers, especially by the sim teams, just purely based on the ethical and financial implications. And finally, to the meat of this study and why I'm here today is the health economic study. So when we think about the Kirkpatrick pyramid levels, we've looked at all of them, and this would be the fourth. Thinking about what is the benefit to the organisation. Well, we just stuck with the appendicectomy, and we are going to expand this over the coming year. But looking at just the appendicectomy, we know that we can increase the efficiency, reduce the complication rates, and improve the surgical skill. However, we wanted to see whether we can save money. And if we were to just use, so bear with me here, we think of a scale between 10% to 100% of translating that 66% time saving, which was our highest. At 10%, we can save £79 per patient. That's about $90. I think this was when we were close to parity. I think the pound is a bit stronger today. But at 100%, we were looking at about £455. saving. So, I mean, this is obviously going to be a scale, and part of our studies, future studies, really diving deep into level 3 outcomes will allow us to choose which percent suits the best for this particular operation. But we extrapolate that across the number of hospitals in both the US and the UK, and we can see almost $1 million for the UK saving just the first year, accounting for the cost of the hardware, and almost 4.3 million in the US, because just the sheer number of hospitals you have. So in terms of discussion summary, we want to deep dive into to the complication rates. We want to talk more about increased patient turnover, potentially readmission rates, which are really important to the US, especially thinking about the economic benefits of patients going back to work sooner as a result of shorter anesthetic time or skin to skin time, and shorter number of steps in the actual operation. But putting all that aside, that's for the future. There is a strong evidence now for faster skill acquisition, confident surgical skill, and safety by utilizing augmented reality training, and it's preferred, it's more effective at providing clinically translatable, scalable, cost-effective laparoscopic training. And we talk about it being potential new gold standard, and that's really for hopefully us and you to think about. So thank you so much. I've got some videos here, hopefully they'll play, and I'll kind of play some of them at the same time. You can see just the kind of modules that some of the trainers were using. These were real instruments, real sutures, real staples. Welcome any questions. Thank you.
Thank you so much. The very interesting, since we are struggling with ROI, the showing the value of the simulation training into the actual numbers. So I found this study. But my problem is that how did you come up with the 10% time saving? Is it from the training? The training is doing 10% faster in the simulation. Is that how you came up with it, or?
Good question. So just to clarify, it was 66% time saving was our highest. What we did to get those numbers is we assumed that only 10% of the 66% was going to be translated into actual time saving in the live theatre room, which is why I had it as a scale from 10 to 100. We were assuming the most conservative amount. So essentially we were assuming that 10% of the 66% time saving was going to end up on the patient, essentially. And for that, we were saving £79. But if we were to scale that all the way up to translating 100% of that 66% time saving, then we were looking at a much higher number. So we were trying to be as conservative as possible for scientific reasons. But as I said, that's going to be for our future study to really find out what is that percentage translatability are we looking at? What's the real figure? Is it 10%? Is it 100%? Probably somewhere in the middle. But that's going to be for future study.
Other questions? Thank you very much.
Thank you very much.
All right, our final presentation, the